So adult patients with acute lymphoblastic leukemia typically have a poor prognosis because they tend to have more resistant leukemia, and because of side effects from treatment, they can oftentimes have severe complications. It can even lead to their death. So their outcomes are not very good. There's a concept now of minimal residual disease, or measurable residual disease, we call it, where we can assess patients' response to treatment. And if they are in a remission by our conventional criteria, but they have small amounts of leukemia in their bone marrow, we know that they're more likely to relapse as they continue their treatment. So there's a number of immunologic agents that have been utilized now in recent years that have shown benefit in patients where their leukemia has come back. And in particular, there's an agent called Blinatumomab. Blinatumomab is what's called a bispecific T-cell engager molecule. So it brings a T-cell close to a leukemia blast cell and kills it. This is approved in the United States by the Food and Drug Administration for patients with relapsed refractory disease where their leukemia has come back or hasn't responded to treatment, and also patients that have this MRD, or measurable residual disease, positive state where we know they have a high risk of relapse. However, we know that patients that get into remission and are still MRD negative, so they seem to have a better prognosis, but we know that they can still relapse down the road. So in this E1910 clinical trial that we conducted in the United States through the National Clinical Trials Network, we aimed to see if adding Blinatumomab to chemotherapy in patients who were MRD negative could lessen their risk of leukemia coming back. So patients underwent 2 months of induction chemotherapy, then they got some additional chemotherapy to prevent the leukemia from showing up in their central nervous system. And then at that point, we assessed their measurable residual disease status. And if they were MRD negative, then we randomized them to continue more chemotherapy that we call consolidation chemotherapy, or to give them 4 cycles of Blinatumomab plus the 4 cycles of chemotherapy, and then they went on to maintenance therapy. The Blinatumomab is given by a continuous IV infusion for 4 weeks. So there were 4 cycles of that interspersed through their treatment. And what we showed was the patients that got the Blinatumomab compared to the patients that got the conventional chemotherapy did much better. Their overall survival at 3.5 years was 83% compared to 65% for the patients who received the chemotherapy only. And this mainly was because we prevented their leukemia from coming back. So those patients that got the Blinatumomab plus chemotherapy relapsed less. So we're very encouraged by these results. We think it's a new standard of care, and that it's something that needs to be considered in the management of these patients going forward.